announcements. Just a reminder that we have the upcoming Donald E. Olson Memorial Lectureship. There are flyers for this outside. This is still a few weeks away on Tuesday, May 16th. And we'll be hosting Dr. Bob Censor of the Centaur Criteria from University of Alabama. Should be a wonderful talk. He will be discussing learning to think like a physician. Next week, we'll be hearing from Dr. Fawn Wolf. She'll be discussing hypogonadism and specifically low testosterone and its treatment. Today, we're joined by Dr. Maxine Bauer. Dr. Bauer is a practicing obstetrician and gynecologist with Providence Women's Clinic here at Providence St. Vincent. She earned her medical degree from Emory University in Atlanta and did her residency in OB-GYN at OHSU here in Portland. She has a wealth of clinical experience, was in private practice here in Portland for 14 years before joining the Providence team, and she's particularly known for her compassionate care and really helping patients walk through the most difficult times in their life. Dr. Bauer was a recent speaker at the PMG Primary Care Conference, and we're delighted to hear her thoughts on this very important and due topic here at Grand Rounds. Thanks.
Okay. So good morning. I'm going to talk to you guys today on some of the most important CDC updates and practice recommendations for contraceptive use. I have no disclosures to share, and I was told to save about 10 to 15 minutes at the end for questions. This is a broad topic, and I will do my best to leave some time for questions at the end, but I'm also happy to stick around afterwards to answer any additional questions. So contraception is a particularly timely and relevant topic to review right now, as so many of our patients have become very anxious about whether their birth control method is about to become significantly more expensive for them. When I first put this talk together for a primary care conference in February, social media warnings urging women to talk to their doctors about long-acting contraception had gone viral, and women began seeking appointments regarding their contraceptive care in record numbers. And really this happened after the election of President Trump. This article here was published in the Oregonian in February talking about this very phenomenon. And at the heart of the matter was concern over the repeal of the Affordable Care Act, which mandates the coverage of contraception for many of our patients. If repealed, which of course was recently unsuccessful, it was unclear whether contraception would be covered for a covered benefit for women in the future. So in addition, there have also been concerns that Planned Parenthood, where many of our underinsured and uninsured patients are receiving their contraception, would be defunded by our current administration. So immediately after the election, there was a 900% increase in placements of IUDs nationwide. Pretty remarkable. So many of you may already have been seeing these patients who are coming to discuss long-term contraceptive options with you. So I'm excited to be here today to talk to you about what is really a very relevant topic and hope to leave you a little bit better prepared to advise your patients on this. So of the 3 million women with an unplanned pregnancy last year, almost half of women were not using contraception. So since about half of women with unplanned pregnancies are not contracepting, it seems logical that one way of reducing unplanned pregnancies is to identify the group of women who are not contracepting, educate them about contraception, and then help them to get started with a contraceptive method. But what I'm most struck by and interested in focusing on today is this group of women, the 53% of women that are using contraception but ended up with an unintended pregnancy anyway. So when I look at this graph, what I see is that we as a healthcare system are not doing a very good job at educating our patients about birth control. And for those women who are actively contracepting, we are either not helping to select the optimal method of birth control for them, or we're not doing a very good job educating our patients on how to identify and manage imperfect use of the method that they've chosen to use. So if we look at the graph on the left, we do see a very different view of reproductive age women, which is to say that a high percentage of women are actually using birth control and using birth control correctly. So in the big picture, it's not as doom and gloom as the graph on the right might lead you to believe. But it's important that we talk to patients about contraception and we check in with them for all patients of reproductive age. So with that introduction, I'm hopeful that my talk today will help all of us to reduce the number of unintended pregnancies in our particular patient population that we see. And objectives are to review the CDC's new practice recommendation guidelines regarding contraceptive use. And hopefully by the end of today, you'll feel comfortable initiating a use of a contraceptive method, knowing what exams and tests are needed before you start each particular method, know what the follow-up is needed, and have some tools to address common problems that arise with daily use, including things like, what if I missed a pill, or I have irregular bleeding with that method. And finally, I'm going to review some of the updates in emergency contraception. So the majority of my slides are from the CDC, which are great resources. You can download and share these with your patients. This is a great pictorial overview of the effectiveness rates of various family planning methods. So the percentages indicate the number out of every 100 women who experienced an unintended pregnancy within the first year of typical use of their contraceptive method. And they're arranged from the least effective at the bottom to the most effective at the top. So I'm not going to spend a lot of time on the lowest effective methods, but not every candidate is, not every patient is a candidate for the most effective methods of birth control. So I think it's worth kind of going over a few highlights in the bottom row here. So we'll start with condoms right here. So condoms are the most effective method of birth control for reducing the risk of sexually transmitted infections. There are 3 types of condoms: latex, polyurethane, and natural membrane condoms. All condoms are porous and should, if intact and used correctly, prevent the passage of sperm. Polyurethane condoms are 2.5 to 5 times more likely to break than latex condoms. And the pores of the natural membrane condoms are 10 times the diameter of the HIV virus. So natural membrane condoms are not likely to be effective in preventing transmission of HIV. For those patients who are using latex condoms, they should be advised to only use water-based lubricants, as the oil-based lubricants will decrease the efficacy of the latex. So female condoms are less effective in preventing pregnancy when compared to the regular use of condoms, and they're probably slightly less effective in reducing the transmission of sexually transmitted diseases. But really, for some women, to not have to rely on their partner to use a condom, this can be very empowering and helpful for them. Use of spermicides disrupts the vaginal epithelium and may actually increase the transmission of STDs. So because of the irritation that it causes to the vaginal epithelium, really the main role for spermicide is with a patient who's using the diaphragm or using the sponge where it's actually inside of the sponge. But really, there's not really a role necessarily for spermicide otherwise. So a high percentage of couples will use the withdrawal method. And I don't know if I was surprised or not surprised, but 11% of our teenagers also use the withdrawal method. But given the high rate of failure with withdrawal method, I usually counsel patients who opt to use this method of contraception. I have them start a prenatal vitamin, and then I give them information on emergency contraception if their goal is really to not be pregnant. So natural family planning. The criteria for a woman to reliably use natural family planning is that she should have a regular cycle. And the cycle length should be between 26 and 32 days. So if her cycle is shorter than this or longer than this, this will not be a very reliable method for her. Patients should be instructed to avoid intercourse or use alternative contraception on days 8 through 19 of the cycle. And for women who do not want to be sexually active when they have bleeding, depending on their cycle length, this method may not provide patients with very many opportunities to have unprotected sex. So if a couple chooses to use this method of birth control, if the woman has 2 cycles that are either less than 26 days or greater than 32 days, they should be advised that this isn't necessarily a reliable choice for them. So moving on to the next tier in effective methods, so this middle tier here, you can see that the combined oral contraceptive pills, the ring and the patch, all have a similar level of efficacy. So when a patient comes to me wanting to start a birth control pill, I always take a thorough menstrual history and contraceptive history. It's really important to know what your patient has used in the past and whether or not she was satisfied with that method of birth control. So there are 2 hormones in the birth control pill, the estrogen and the progesterone. And it's usually the progesterone that most patients end up having symptoms from. So if your patient has had an experience with birth control pills in the past, it's really helpful for selecting a birth control pill for the future. So if somebody did really well on triphasal, or they said, I was super irritable on low estrogen, or I gained a lot of weight on orthocycline, you can take that information and avoid that particular progesterone in your next selection for them. So I tell patients that it's a little bit of trial and error, and you kind of have to try on the pill to decide whether you're going to tolerate that particular one. So if you have a history to work with, then you can be better at selecting what you would like to choose. So I use this book on the right here, The Managing Contraceptive Pill Patients, pretty regularly in guiding my choice of pills for a patient. And it has 2 tables that are particularly useful. The first is a list that has the composition and identification of all oral contraceptives marketed in the United States. And this is a pretty comprehensive list that breaks down which hormones are in the pill, what the doses are, the colors of the pill, so your patient can identify what they've been on in the past, and the inactive ingredients, including generics. So that's super helpful for those of us who are prescribing regularly. There are so many to choose from, and it's nice to have some basic information to start with. So the second table is called the table of contraceptive pill activity, which ranks various pills according to 4 categories: their endometrial activity, their estrogenic activity, their progestational activity, and their androgenic activity. So for example, Yaz, which is a highly anti-androgenic pill, gets a 0 for androgenic activity. So for our PCOS patients who have hirsutism as one of their primary complaints, this is an outstanding pill choice for them. So we just talked about how there are different kinds of progesterones. These are the 5 different types of progesterones that you have to choose from. So your first choice when you're trying to prescribe a pill is determining what progesterone you're going to choose. And all pills have ethinyl estradiol, just in varying doses. So the estrogen is going to be between 20 and 35 micrograms. A slightly higher dose of estrogen may be helpful in reducing the formation of functional cysts. So if you've had a patient who's had simple cysts or hemorrhagic cysts, this is a good choice for them. It may also be helpful in addressing patients with androgen-related symptoms. So higher doses of estrogen will improve they'll reduce the amount of free testosterone that's around and 5-alpha reductase activity. Now, some women are particularly sensitive to shifts and changes in their hormones, and these patients will often tell you that their depression and mood changes with their cycles. They get irritable or frustrated. They get really impatient. Some with the birth control pills, some with their own cycle. And for patients who are really sensitive to shifts in their hormones, a monophasic pill, which is one where the hormone level is the same throughout the cycle, is probably the best choice for them.
Any idea what percentage of women might fall in that category?
I don't know the answer to that, yeah. So the triphasic pill was really designed to be more physiologic. It's usually the progesterone dose that varies in the triphasic pill, and the overall dose that patients get in the triphasic pills tends to be a little bit lower. But for people who do get headaches when their hormone levels change or things like that, it's probably best to consider a monophasic pill. So let's talk about starting the pill. When starting a birth control pill, a backup method of birth control is needed if the pill is started greater than 5 days after the period is started. So patients should abstain from having sex or use a backup method of birth control for a minimum of 7 days once they've started the pill. I like going with the Sunday start, and I check the patient's blood pressure before starting the pill, and at some interval after they've been taking the pill. But I also tell patients that the worst pills to miss are the first pill of the month and the last pill of the month. The longer the pill-free interval, the higher the likelihood of ovulation and failure with the birth control pill. So this is why, if you've ever had patients who've been on birth control pills for a long time, and then they stop in order to get pregnant, there's a higher percentage of women who actually get pregnant right after stopping the pill, and they never get their next period. I have always done a Sunday start, thinking that it would reduce the amount of irregular bleeding, the Sunday start after their last period. But recent studies are kind of debunking this concept that you have to start on a Sunday after their period. So the best reason to really start taking the pill around a woman's period is that it minimizes the likelihood that they're pregnant when you're starting the birth control pill, but it can really be started at any time during the cycle. Okay. I'm not going to go over the contraindications for birth control pills. So what if I miss a pill? I think it's really important that we talk to patients about the imperfect use of the birth control pill. So if you miss a pill, you take the first pill you missed as soon as you realize that you missed taking it until the following day. And then if it's the following day that you realize that you missed the pill, you can take 2 active pills at once. So generally speaking, it's not a problem to miss a pill. However, as I mentioned before, some pills are worse to miss than others. And if you miss and extend your pill-free interval, then really women should consider using a backup method of birth control. And that needs to be done for 7 continuous days of hormone before they can feel like they have adequate protection against getting pregnant. So if 2 or more pills are missed, instructions to the patient are a little bit more complicated. And the next steps really depend on whether or not the patient has had unprotected sex within the last 5 days. So if the patient has not been sexually active within that time frame, she may take 2 active pills at once and then use a backup method of birth control for the next 7 days. If she has been sexually active, then this patient may be suitable for considering emergency contraception. So the patient takes emergency contraception and then restarts the pill the next day to finish the pack. That kind of depends on what method of emergency contraception they use. And then they use a backup method of birth control until they've completed 7 days of continuous hormone use. So sometimes I will ask patients to kind of describe back to me what they would do if they missed a pill. You can see that this kind of requires a little bit of health literacy for patients to be able to know what to do if they miss a pill. I have a handout that I give to patients with a long explanation of what to do if I miss a pill. And I'm not sure how many of my patients find it useful, but I know my staff really does. And sometimes they call, and that's a good guideline, to have our staff be educated too. So, and I also educate patients about emergency contraception every time I write a prescription for the birth control pill. So the vaginal route of delivery increases the bioavailability of hormone and therefore enables use of a lower total hormone dose. So the NuvaRing is a pretty forgiving method because the hormone levels remain therapeutic for up to 35 days after the application of the NuvaRing. So you'll know that this is worn vaginally for 3 weeks at a time. So if a patient left it in place and forgot to remove it up to almost 2 weeks late, it probably is going to be okay. But this is a particularly useful method for those patients who just can't seem to remember to take a pill every single day and are having trouble for that. And I also tell folks that the ring effectiveness does not really depend on where it is in the vagina. So this graph essentially shows the pretty steady state hormone level that you see with the vaginal ring. And this is also true with the patch. So for patients that do not like that change in hormone levels, this is really ideal. The days of the cycle didn't show up on here, but this represents around 30 days right here when the hormone level slightly starts to decline. So the NuvaRing is indicated for up to 28 days of use. But the package inserts will have patients wear it for 3 weeks at a time and then have the withdrawal bleed for 1 week. So I will also just point out quickly that because the hormones are absorbed vaginally, the estrogen and progesterone are metabolized differently than combined oral contraceptives. They bypass first pass metabolism by the liver. So the patch is a 4.5 centimeter square that delivers 20 micrograms of ethinyl estradiol and 150 micrograms of progesterone. The progesterone in the patch is norelgestromin, which is an active metabolite of norgestimate, and it takes about 3 days to reach a steady state hormone level with the patch. And this steady state remains there for 9 days, so recommendations are to change the patch at 7 days. It can be worn anywhere on the body except the breast. It is not considered a first-line option for women over 200 pounds, as the studies that they did have shown that it's less effective in obese women. But I would say that a non-compliant obese patient who is willing to use the patch is probably going to have better contraception than if she doesn't use anything at all. And sometimes I will talk to my obese patients about the possibility of using a second method of birth control if they're interested in doing the patch. So the what ifs with the patch and the ring are a little bit more complicated. So we'll just do the NuvaRing to start with. So if the NuvaRing is out, if the patient forgets to reinsert it, patients can leave the ring in while they're having sex if it's not bothersome to them or to their partner. But many patients will take out their ring in order to be sexually active. So some people forget to put it back in, or they forget to change at the end of 3 weeks. So if it's been less than 48 hours, then they can reinsert the ring as soon as they remember to do that. It is not likely that additional contraception is needed, but it does depend on when in the cycle they have forgotten to reinsert the ring. So if it's super close to the time that they've had their 7 days without any hormone, that's probably a really concerning time. So if, again, if it's been over 48 hours, it's just kind of like with the pill. You need to assess whether that patient has been sexually active or not. It should be reinserted as soon as they remember to put it back in. They should be using a backup method of birth control until they've had 7 consecutive hormone days. And emergency contraception should be considered if they've been sexually active within 5 days of unprotected sex. So as far as when you can start, the patch and the ring are very similar to the birth control pill. And they follow pretty similar rules. So basically, you can start them at any time during a woman's cycle, and I like to check blood pressures before we get started, and then I have them return several weeks after starting their method of birth control, whether it's the ring or the patch or birth control pill, to make sure they're doing okay. I talk to them about misuse and, okay. So going back to our chart, you might notice that progesterone-only pills are not listed on this chart. And I've always counseled patients that progesterone-only pills are less effective than the combined oral contraceptive, and this is really due to several factors. So first, unlike combined oral contraceptive pills, the progesterone-only pills only inhibit ovulation in about half of cycles, which is kind of amazing. The peak serum levels of progesterone are reached about 2 hours after a patient takes the pill. And if you were to measure their steroid hormone levels at 24 hours after they've taken the pill, they're back at their baseline. So a progesterone-only pill is considered missed if it's been greater than 3 hours after they were supposed to take the pill. So the birth control pill is a little bit more, the combined oral contraceptive pill is a little bit more forgiving from that perspective. But if you do have a patient who can't take an estrogen for some reason and they are using the progesterone-only pill, it's really important if they're relying on that for contraceptive purposes to be reliably taking it. So the last method in this middle category here is the injectables. Depo-Provera has two types of injections, and you guys are probably most familiar with the crystalline suspension, which is the 150 milligram IM dose. It's given in the deltoid muscle or the gluteus maximus muscle. But there's also a subcutaneous version of Depo-Provera that's a slightly lower dose. It's 104 milligrams. And this was designed with the intention of self-administration for some patients. The injection that most of you give is given every 3 months or 13 weeks. It can be given earlier if a patient needs to adjust the schedule. And it can be given up to 15 weeks without being concerned that you need to provide a backup method of birth control. Patients should be counseled on the expectation of having irregular bleeding during the first year. And there's generally a progression to amenorrhea for about 50% of patients. So for those women who would like to only contracept for a brief period of time and then try to get pregnant, especially our older patients, 35, 36, who have delayed their childbearing for a certain period of time, it can take up to 9 to 12 months for ovulation to resume reliably after using Depo-Provera. So I always like to figure out what my patient's desire is as far as their future fertility when using Depo-Provera. And I just want to make a brief comment about the black box warning with long-term use of Depo-Provera and osteoporosis. So at this time, ACOG and the American Academy of Pediatricians, they do not recommend limiting the use of Depo-Provera or having a bone density scan for our patients. And this is probably because the effect of bone is, the effect on the bone is reversible. And the effects seem comparable to that seen on patients who have been breastfeeding for long periods of time or using the progesterone-only pill. So I tend to counsel my patients who've been using Depo-Provera for a long time on adequate calcium intake, having weight-bearing activity, adequate vitamin D, and certainly if they're smokers, not smoking, especially in our teen population. So Depo-Provera can be given at any time during the cycle. No examinations or tests are necessary before getting started with it, although some studies suggest that it's nice to get a BMI before you get started and compare that. And each of these slides, there's maybe 3 or 4 that you'll see repeatedly here, are easy to access and are good reminders and guidance for you through the CDC website. So moving on to the last tier of our most effective methods of contraception, we're going to review implants and IUDs. And you may see these referred to as long-acting reversible contraception or LARCs. So the implant or Nexplanon actually has the lowest failure rate of any method of birth control, including tubal ligation, vasectomy, and IUD. And for those of you who remember inserting and removing the Norplant, This is so much easier than that was. There were 5 little rods with the Norplants, and they would be really a bear to get out when they'd been in place for a number of years. But these are really pretty easy. You do have to go through the training course to be able to insert the Nexplanon. It has a 68 milligram rod, and I learned this past week that it actually is radio opaque, so you can see it on an x-ray. It can be placed at any time during a woman's cycle, provided she's not pregnant. And patients should really be counseled on irregular bleeding and be okay with this possibility. So while almost a quarter of patients will not get a period, a significant percentage of patients are going to have irregular bleeding, of which 7% have frequent bleeding and 18% have prolonged bleeding. So 25% of patients will have a significant amount of bleeding with the Nexplanon. So you can imagine they've tried to look at different things to reduce the amount of irregular bleeding with Nexplanon. And in general, I would say studies have had pretty unimpressive results. Either if they do see a positive effect, it's in a small study, or it's not been reproducible. But the 2 medications that did show an improvement in bleeding pattern with Nexplanon were the use of oral Celecoxib, which is Celebrex, and it's a 200 milligram dose for you take daily for 5 days. And then Ponstol, which is mefenamic acid, 500 milligrams TID for 5 days. So the IUD. So until the last few years, I've always felt like our country has had a very limited complement of IUDs to offer to patients. And we've sort of taken a one-size-fits-all approach for our patients. And you should be aware that there are many different types of IUDs out there. And if you go to other countries, you'll see that they come in all kinds of shapes and sizes. So we've really been pretty unsophisticated in our approach to the IUD here. But we have essentially a non-hormone secreting IUD, which is the copper T or the Paragard, and the hormone secreting IUDs, which is a levonorgestrel. And now we have the Mirena, the Liletta, Kylena, and Skyla. So as I alluded to at the beginning of my talk, the IUD has become one of the most popular contraceptive options available. So let's talk a little bit about what you need to know to counsel your patients on the IUD. So I explained to most of my patients that this is kind of the no-brainer method of birth control. They don't have to do anything. They can't forget the pill. Its effectiveness is not going to be changed if they start an antibiotic for something. It's a really ideal method of birth control for those folks who do not want to pay attention to their contraception. So the biggest complaint with the copper IUD, so your first choice is whether you put in a hormone-secreting IUD or a non-hormone secreting IUD. So the biggest complaint with the copper IUD is that it makes periods heavier. So if you have a patient that already has a heavy period, they're likely going to be pretty dissatisfied with this side effect. And the Mirena IUD was actually designed to address that complaint. So it secretes progesterone locally at the level of the endometrium, and up to about 20% of women will not get a period who have the Mirena IUD in place. So if you have a patient that has very heavy periods, the hormone-secreting IUD is probably the best way to go. So do you need to do STD screening for every patient? No, you do not. But if a patient has an undiagnosed infection at the time that you're inserting it, it's really best to treat and then delay insertion of the IUD. For our patients who have risk factors, multiple partners, age less than 26, I think it is reasonable to screen at the time of the insertion. It's an okay approach to get your gonorrhea, chlamydia screening at the time of insertion and then treat them if it comes back positive. Prophylactic antibiotics are not necessary for most patients, and there have been studies looking at whether or not inserting the IUD during a period makes it easier to insert, and it does not seem to make a difference. Nulliparous versus multiparous women. So there's probably a slightly higher rate of expulsion of the IUD in women who are nulliparous than in multiparous women. If you have a uterus that sounds less than 6 centimeters, their likelihood of expulsion of the IUD is much higher. And if you have a uterus that sounds greater than 11 centimeters, it's not a guarantee that the IUD will be a successful method of birth control for those patients. The approach that I take for my nulliparous patients are, I usually tell them if they're going to have a hormone-secreting IUD that I will sound the uterus, and if it is a small uterus, then I will consider putting in the Skyla, which is a little bit smaller than the Mirena. So let's compare the different hormone-secreting IUDs that are out there. So the Liletta is really the same as the Mirena in size and hormone dosing. And you'll notice that the Mirena is approved for 5 years, and they're pushing to get that to 7 years. The Liletta is approved right now for 3 years, but that's because the FDA trial is ongoing. And we have every reason to expect that it should be good for 5 years. The commercial cost of Liletta is significantly less than the Mirena. It's $128. And through the federal 340B programs, it's available to public health clinics and community health centers for $50. So it makes it a very accessible and form of contraception regardless of patients' income and insurance coverage. Here at Providence, there's the Arch Foundation, which does supply the Mirena and the Skyla to our economically disadvantaged women whose insurance does not cover the IUD. And the patients that we do this a lot for are uninsured patients and Callum patients. So the Kylena IUD is a relatively new IUD on the market. It's a little bit smaller than the Mirena and the Liletta, but it's wider and shorter than the Skyla. And as I commented, I do think about the size of the IUD when I'm inserting an IUD for a patient. So Skyla is the smallest. And then just for comparison, the Paragard measures 32 millimeters horizontally and 36 millimeters vertically, and it's the most narrow. So if you have a patient with a stenotic os and it's going to be difficult to place it, it's only 3 millimeters in width. So how much progesterone is absorbed systemically from the IUD? It's really negligible, but it's not zero. So with the progesterone secreting IUDs, the endometrial concentration is high, but it really doesn't result in a high plasma concentration. So in the first few weeks of use of the Mirena and the Liletta, you can measure serum levels of progesterone at 100 to 250 picograms per milliliter, and there's a gradual decline of that over time. And if you compare that to the implant, it's 350 picograms per milliliter, and the progesterone-only pill, which is significantly higher. So the IUD can be inserted at any time during the cycle, and a woman may rely on the Paragard IUD for contraception immediately after it's placed. A backup method of birth control is needed for 7 days after the insertion of the progesterone-secreting IUD. For any IUD that's placed, you need to do a bimanual exam, and an inspection of the cervix is necessary. So STD screening should occur for patients with risk factors. So it used to be that if a patient developed PID and had an IUD in place, we would have to remove the IUD. And this is no longer an absolute contraindication to IUD use. So if a woman develops PID and she is interested in keeping her IUD, you should start antibiotics, counsel the patient about condom use, and then reevaluate in 48 hours. If she's improving, she can continue with her IUD and a 14-day course of antibiotics. If she is not improving, then you should consider removing the IUD. And then if a patient does choose to discontinue the IUD with the development of PID, she should get antibiotics on board before you remove it. So she needs to come back after having a couple of days of antibiotics before the IUD is removed. So after I place an IUD, if the patient is able to feel the IUD strings and has no complaints or concerns, I tell them they don't need to return back to the office for a follow-up visit. I always leave the strings 2 inches long. I comment in the chart how long I've left the strings. I tell the patient if it's bothersome to you or bothersome to your partner, we can easily trim it and make it shorter, but you can't make the strings longer. And I can't tell you how many times we've had patients who've come in who can't feel their IUD strings because they were trimmed too short and they got sucked up into the endocervix. And it also makes it really difficult and a challenge to remove the IUD. And every once in a while, we can't get to the strings at all, and that patient has to go to the operating room to remove it hysteroscopically. But this is a great follow-up, a great slide for generalized follow-up information. And in general, patients should be advised to contact you for any side effects or problems that they are having with whatever method of birth control you started them on, or if they wish to change their method of contraception. If they're seen in the office for an unrelated visit, it's really appropriate to ask your patients if they have concerns about their contraceptive use. And it's also important to assess any health changes that they've had that might change the appropriateness of their current method of birth control. And I would say finally, if the patient is on a birth control pill or the ring or their patch, a follow-up blood pressure check is recommended. So very briefly, I'm going to mention the effect of obesity on different types of contraception. So even though obesity may decrease the effectiveness of contraception, it's still, their risks during pregnancy are also higher too. So it's still better than not using any method of birth control. We see a trend that in heavier obese women, they have a higher risk of oral contraceptive failure, particularly on the lowest dose formulas, which means it's probably a threshold effect that we're seeing. So you can see here, this is with the patch, that as a patient's weight goes up, the number of pregnancies also goes up dramatically. So we see this trend with birth control pills, the patch, and the ring, but we actually don't see this same trend in patients who have the implant or with injections. So I'm going to skip over this because this is data on Implanon. We don't have a lot of data on Nexplanon. So I just want to put in a plug for our obese patients who need contraception. The IUD is a terrific choice for these patients. So often obese women are at increased risk for endometrial hyperplasia and endometrial cancer, especially if they are anovulatory or oligoovulatory. So women will make a weak form of estrogen called estrone in a chemical reaction in fatty tissue, and that estrone can stimulate the overgrowth of the endometrium. And if the patient is not ovulating, they're not making progesterone. And it's that extra estrogen stimulation that kind of pushes women into endometrial hyperplasia or endometrial cancer, which is why being obese is a risk factor for endometrial cancer. So the progesterone secreting IUDs are a fabulous option for these patients. It delivers progesterone locally. It can address their abnormal, heavy, dysfunctional bleeding and menorrhagia patterns, as well as provide them with excellent contraception that isn't going to have an increased risk of failure because of their obesity. So bleeding irregularities with contraceptive methods. So as I mentioned before, the copper IUD is pretty often associated with making cycles heavier. We don't really have any good tools to address menorrhagia with related to the copper IUD. But if your patient has intermittent spotting with the copper IUD, then NSAIDs for 5 to 7 days may help. I did not come across any studies for the use of Lystida, but for some of our patients that have fibroids and have super heavy periods because of a fibroid uterus, we've been using Lystida to help decrease the heaviness of their periods, and I think this might be a good option to use for patients who are having menorrhagia related to the copper IUD. Women who have bleeding irregularities with the Mirena. We don't generally see menorrhagia with the Mirena IUD, but we do see intermittent spotting. The patients who have the most problems with this tend to be women who have the Mirena inserted postpartum and are breastfeeding. And what tends to happen with this population is that the endometrium is extremely thinned out because they don't have estrogen on board. And it exposes the basalis arteries that lead right up to the lining of the uterus. So treatment with a little bit of estrogen may help thicken the endometrium and decrease the exposure of these arteries and decrease random bleeding. So patients who get irregular bleeding with regularity on the Mirena IUD may actually benefit from a little bit of estrogen. And of course, those patients need to be medically eligible to treat with either estrogen for 10 days or combined oral contraceptive. So I'd be remiss if I didn't mention this resource to everyone. So this is the U.S. medical eligibility criteria chart, and it's a wonderful resource that walks you through some of the most common medical conditions and presents what the, some of the optimal contraceptive options are for your patient. So number 1 is no restrictions. And number 2 says the advantages likely outweigh the theoretic risks. And number 3, risks usually outweigh the benefits. And a number 4 means contraindicated. So I know this is really small, but if you look under headaches of migraines with auras, you will see that oral contraceptives would get a 4, meaning it's contraindicated, and the remaining methods of birth control, the IUD, progesterone-only implants, they get a 1. So this is a nice little chart just to kind of have in mind, especially if you have a patient with a medical problem and you're trying to figure out what might be the best option for them. So when I gave this talk about 2 months ago, it was for Providence physicians, and I ended up creating, for those of you who do practice in the Providence system and are on Epic, these are some smart phrases that I use in my patient visit summary, and you can steal them. It's on oral contraceptives, patch, the ring, what happens, you know, if I mess up. And they're only in English, I will have to say that, and they may be a little too sophisticated for some patients, but they're there for you to steal and to educate your patients with. And like I said earlier, it's also helpful for your staff too. And then of course there's some information on emergency contraception. So I'm going to try to wrap up with a little brief review of emergency contraception, which is birth control that prevents pregnancy after unprotected sex, and it's sometimes called the morning after pill. A woman can use emergency contraception right away or up to 3 to 5 days after having unprotected sex. So while emergency contraception will remarkably reduce the likelihood of a woman getting pregnant, it is not, in general, as effective as a regular birth control method. In the United States, the progesterone-only emergency contraceptive pill is now available without age restrictions, and it's over the counter. So any person can go to the store and buy it. You have them look for Plan B, 1 step, take action, next choice 1, 1 dose. And it may be in the family planning aisle, or it may be behind the counter. The cost is usually about $40 to $50, with generics running about $35 to $45. Not every pharmacy will carry it, so it's not carried here at Providence. There are 4 types of emergency contraception that are available to patients, and the most effective form of emergency contraception is actually the copper T IUD. It also has the added benefit of providing contraception to the patient afterwards. So the IUD should be placed within 5 days of having unprotected sex, and if the patient has active PID, this is not an available option for them. If they test positive for gonorrhea or chlamydia at the time of insertion, the IUD can be inserted and then they can just be treated after the insertion. So it reduces the risk of pregnancy by 99%, and the most recent studies actually show that the failure rate is just under 1 per 1,000 IUD insertions. And over 80% of women will actually keep their IUD in place afterwards to use it as a contraceptive. So the IUD may be placed and inserted up to 5 days after ovulation, but because most women do not know when they've ovulated, we've sort of simplified the recommendations to say that the IUD should be placed 5 days not later than 5 days after unprotected sex. But if you have a sophisticated patient who knows when she ovulated and she hasn't ovulated yet, you could extend that period of time longer. So I'm going to give a little bit more information on Ella in just a second, but levonorgestrel is what Plan B is. It can be given in a single dose, which is 1.5 milligrams, and it's available over the counter without a prescription. It's highly effective, especially if a woman takes it within the first 3 days. If you compared it to Ella or ulipristal acetate, Ella becomes more effective if the later you get from unprotected sex, so between days 3 and 5. So a patient can take either the 1.5 milligram dose one time. She can take 0.75 milligrams 12 hours apart. Early start is better, so it really reduces the risk of pregnancy. So if a patient takes it within 1 day of unprotected sex, she'll reduce her risk of pregnancy to 0.4%, and the later start in that 1 to 3 day period, the risk of pregnancy is 2.7%. So, as I said, it's not available in all pharmacies. I'm going to give you a website that you can give to patients and share called www.gotoplanb.com. That can lead them to where they could buy this for themselves. And main side effects are spotting. And then finally, any birth control pill can be used as emergency contraception. And this website that's up here at the top, the www.ecprinceton.edu, it's a fabulous resource for patients and providers. And what I like about it from the provider perspective is that it has an oral contraceptive pill reference table where you could take any birth control pill and it's going to tell you how to prescribe that as emergency contraception. And many of you may remember the UTC kind of methods that we have done in the past, but for patients who may not necessarily have easy access to a pharmacy where they can get some of these medications, they can just use a birth control pill and recreate it. So this brings me to Ella, which works by delaying ovulation for a full 5 days following unprotected sex. Its a mechanism of action is a progesterone receptor modulator. It does require a prescription, and the average cost is about $67. Most common side effects are headaches, 18%, stomach discomfort, 12%, nausea, 12%, cramping, 9%, and fatigue, 6%. It should not be used more than once in a menstrual cycle. If the patient has sex again during the same cycle, a reliable barrier method should be used because sperm can live up to 5 days. And if your patient is just delaying ovulation and they have unprotected sex and that's what they're using for their their emergency contraception, that's not going to work out so well. So they need to have protected sex and use a barrier method for a period of time. And it's usually until they get their next period. So if your patient is opting to use hormonal birth control, they also have to wait to start that as well. So you might ask, well, what are the advantages of Ella? Well, it's more effective if somebody is taking it at a delayed period of time. There is a greater risk of pregnancy in obese women, and it is generally considered more effective than the levonorgestrel. So last point, taking hormonal contraception will decrease the efficacy of Ella. So they have to wait until they are at least 5 days out from taking Ella before starting a hormonal method of birth control. So kind of to summarize on emergency contraception, just make sure your patients know about it. So no, you don't actually have to prescribe anything, but just letting patients know that they don't need a prescription is important and that it's available, even for those patients who are actively contracepting. This is something where they have to pick one method. You don't use more than one kind. It's not like, oh, I'm going to make sure I'm not pregnant. And in fact, actually, if somebody takes Ella and then takes Plan B, they're probably making both methods less effective. And patients don't need to take extra pills. That's not going to make this more effective. Review expected side effects, which for most are going to be GI symptoms, stomach upset, nausea. You can give patients an antiemetic to help with that. And advise patients they should get a period within a month, and if they don't, they need to contact you. And then this is a great opportunity to step in and say, let's talk about a regular method of birth control for you. And then these final websites down here, www.nottolate.com is a great resource for patients. And I've put them in my smart phrase that I hand out to patients with information about emergency contraception. And the go-to-planb.com is also a good resource for them to know where they can go to buy Plan B. So I think I'll end with that and leave some time for questions. Yeah.
That's great. I have two questions. One is that you didn't really talk about continuous hormonal therapy, and most of my patients, I have them use their oral contraceptive continuously.
Mm-hmm.
And then the other is, because I'm so old, I was sort of shocked to find out the number of my young patients who use Plan B, who aren't in a regular relationship, they use Plan B as their normal birth control. And should I be shocked, or is that a reasonable thing to do?
It is not reasonable. I mean, it is not ideal. Like I said, I think that it's a good time to educate patients on this really shouldn't be the best way of addressing contraception in general. But I'll start with your first question about the continuous use of birth control pills. So nobody has to have a withdrawal bleed. Some patients really want that so they know that they're not pregnant. That's really helpful for some of our younger patients. For patients who have endometriosis or really headaches with changes in their hormones, menstrual migraines, it's a great way of going. And there's no there's no health reason not to be able to do birth control pills continuously. Now, with that said, the birth control pill is a progesterone dominant pill. And so what happens is over longer periods of time, the effect of progesterone dominates. And so there isn't enough estrogen in the pill to make the lining of the uterus thick enough. And that same phenomenon that I talked about with the Mirena IUD in breastfeeding women starts to happen with continuous use of birth control pills. So people tend to get a little bit higher rate of breakthrough bleeding with continuous oral contraceptives. And for some people, that's not a big deal because they're just not getting their period. For other people, that's really an annoying thing, and they just do not like unpredictable bleeding. So it's kind of a patient preference type of thing. But there's no health reason that you have to have a period. And in fact, when the birth control pill was first designed, it was given continuously. There was no period, and women did not like that. They were super anxious about it, and they were like, well, how do I know I'm not pregnant? So it evolved to have a withdrawal bleed. So.